Urinary tract infection, as we know now, doesn't really fit into those boxes and yes, no questions, and it's a lot more complicated. And this has really been impacted by the diagnostic tests, and as you say, the midstream urine culture in particular.
Dr. Malcolm Starkey is an Australian scientist dedicated to improving the lives of people affected by urinary tract infections and related bladder and kidney conditions. He leads the urinary tract disease research group at Monash University and founded the Bladder and Kidney Health Discovery Program to drive new treatments and diagnostics where they're most needed. His research explores why some people are more vulnerable to recurrent UTIs and kidney problems, focusing on the role of microbes and the immune system. Beyond the lab, he works with global alliances, women's health networks, and patient advocacy groups, and is passionate about inspiring the next generation of scientists through teaching and mentoring. Thanks so much for taking the time to answering our community's questions.
Melissa, thanks so much for having me, and thank you so much for this great initiative. I think it's really fantastic to engage with researchers and connect with the community, and it's a real pleasure to be here.
It's been exciting for our community to see so much more research happening. When I started Live UTI Free 8 years ago, I could hardly find anybody working in this space that was willing to engage with patients. But now, every time I speak to someone, they recommend other researchers in the space, and most of them are happy to chat with us. So that's been really encouraging. And I'd love to hear more about your background and how you came to be working in the UTI space.
Sure. And look, it's fantastic to hear. And as I was saying to you before, I think this community now in this space is really fantastic. And I'm really excited about this next generation of researchers and the impact that we can have together. And thank you again for the initiative. So originally, I was a respiratory immunologist and
Mm-hmm.
microbiologist. And I came about looking at urinary tract diseases when I sort of, I guess, became an independent researcher. And at that point in time, when I was setting up my own independent laboratory at Monash University, I asked the question of what's something I can do that's really impactful and
Mm-hmm.
important and something that I'm really passionate about that can combine my existing expertise in immunology and microbiology. And so I settled on urinary tract diseases. And perhaps there's a little bit of a background story there, Melissa, because
Mm-hmm.
I actually have a chronic kidney disease and I
Right.
received a kidney transplant in January 2024. And so whilst I'm not researching the diseases that affected me, I think it made me acutely aware of the lack of awareness and education within the
Mm-hmm.
community, within our governments and within our health sector, and also within the scientific fields of urinary tract diseases more broadly. So when I decided what can I do that's going to have the most impact, that's what made me land in this space. And of course, urinary tract infections is a major component of understanding host microbe interactions, so
Mm-hmm.
microbiology and immunology in the urinary tract. And so that's how I got here.
It's always interesting to hear how people arrived here because they're so different, all the backgrounds. And personal experience is how I ended up here doing the
Mhm.
health psychology research that I'm doing. Interesting to hear that you also have an experience that led you here. One of the
Mhm.
things that we talk about a lot in our community, and I think is the thing that's behind a lot of these prolonged experiences with UTI, is the flaws with standard UTI testing. And so we have covered that a lot in our content, but we have a lot of new viewers and a lot of patients that are new to the topic. And I would love to hear from you your thoughts on why standard urine cultures are just not the right test for this illness.
Sure. I mean, this is one of my favorite things to talk about, and one of my
Excellent.
favorite things to, to bring up to the undergraduate students, in
Hmm.
medicine and science as they're coming through, because there's just such a stigma around this testing.
Yeah.
And I think it's really important to sort of bring it back to some basic principles around medicine. So medicine love to have boxes and
Hmm.
names and criteria, and they love to have tests that basically say yes or no or have some kind of a threshold. And then that allows them to say yes, no, and then they follow guidelines for treatment. Of course, urinary tract infection, as we know now, doesn't really fit into those boxes and yes, no questions, and it's a lot more complicated. And this has really been, impacted by the diagnostic tests, and as you say, the midstream urine culture in particular. So when we think about these bacteria that we can culture, it's predominantly E. coli. So they're the bacteria that really become dominant in these detection assays that we use in the diagnostic labs. And so there's the potential that we lose lots of other uropathogens that
Hmm.
might be causing the infection. Of course, it also relies on detecting bacteria in the urine. Now, these bacteria are very clever, and of course, they've evolved to be able to embed themselves within the urinary bladder lining, which is called the urothelium. And so they hide out here. And so when they're not in the urine, when they're hiding out in the bladder lining, we just can't see them in the urine. So then the test comes back as negative. The other problem is for many diagnostic labs, they have a very high threshold of diagnosing infection, which is often around 100,000 colony forming units of
Hmm.
bacteria per ml of urine. And this number came about because of a study from the 1950s that was looking at infection in pregnant women that developed a kidney infection called pyelonephritis, which can be quite serious, both for
Hmm.
mum and baby. And even in that study, they recognize that this is an arbitrary sort of cutoff. It's okay for looking at this kind of infection in pregnancy, but it's not to be used for standard UTI. However, if you look fast forward to now and you look at every single guideline across the entire world, everybody's using this
Hmm.
threshold as their diagnostic threshold. So even the original study suggests that this shouldn't be done. And then we get variation in this threshold. So even here in Melbourne, we have some hospitals that lower that a little bit, some that keep it 10 to the 5. And so it's inconsistent, which makes it really
Hmm.
difficult for patients to understand. On top of that, a lot of diagnostic labs will exclude tests that have human cells called epithelial cells in that sample, because the assumption is that that's contamination from the skin and that therefore you could be culturing bacteria from the skin. Of course, we know that the urinary bladder is one of its first line defenses to the pathogen. It will actually shed the bladder lining, which are epithelial cells.
Hmm.
And so when we see those cells in the urine, it's very likely that's a very strong indicator of an active infection. However, the diagnostic labs will say that's contamination, and
Hmm.
therefore that'll come back as no positive result. We now know that if we culture the bacteria out of those cells or even stain for bacteria within those cells in urine, we can see them packed full of uropathogenic E. coli, these main bugs that cause the infection. So really, everything's there. We're just not looking in the right place. So I think the key message is don't just test the urine. We need to test the cells as well. And of
Hmm.
course, we're not doing that. And so I think we have some fairly simple things that we could do to change diagnostics, but we kind of have to go against decades and decades of inertia in medicine, which is, as you're aware, Melissa, a very difficult thing to change.
It's so frustrating though. I know this information, and every time I hear it, I just can't help thinking, how do we still have this test as the gold standard up to 70 odd years? And
Mm,
even the test itself wasn't designed for this purpose in the first place. They knew the threshold was arbitrary, and we've just stuck with it. And
mm,
instead of changing the test, patients are just told that this is all in their head, and the test is
mm.
clear, therefore you don't have a UTI, or therefore nothing is wrong with you, which is, it gets me even more. Your symptoms are imaginary. What do you think a new test in the future might look like?
Look, I think there's lots of ways we can pursue this, and this is something we're doing in the lab as well as many others internationally. So I think we need to be identifying non-bacteria related factors,
Hmm.
so what we call biomarkers, so factors that are coming from us, the host.
Hmm.
So often what happens in the field, typically over the past decades, is that all the research is largely focused on, for a long period of time, the bug, so the bacteria, and the drug, the antibiotic. And so it's not just all about the bug and the drug. We're the thing that's getting
Hmm.
infected. And so what our body has to say to that is really important. And so looking at the factors that we produce in response to that infection could be really important because we could identify host factors in the urine, for example, even though we can't see bacteria, that shouldn't be there unless we're really
Hmm.
trying to fight off an infection. So that would give us a really good indication. So we can look at that and we're doing that. And we can do that via all sorts of really complicated processes. And so we're trying to narrow that down. I also alluded to before in answering your previous question, I think really some of the answers already there. Like if we
Hmm.
just stain for or bust open those cells and culture them, or don't even exclude those cultures that have the contamination, then we're already going in the right direction. I think the other thing we can do immediately is to just, standardize and realize that it doesn't have to be such a high cutoff.
Hmm.
If you've got symptomology, even with, 10 to the 2 or 10 to the 3 bacteria, it's very likely to be an infection. So there's some low-hanging fruit there,
Hmm.
Melissa, that we could look at in the diagnostic labs, of course. And then there's also some higher end scientific approaches that we can do looking for biomarkers of host factors that we can detect in the urine.
And it seems like a lot of the problems with the test not being accurate is this chronic UTI concept, which I think is fairly well established in the research, but not so much in a medical sense.
Mm.
Like in clinic, there's no consensus around the definition of chronic UTI. What do you think it should be defined as?
And again, this is the problem generally with medicine, right? And as we were saying before, with our personal experiences, being a transplant recipient,
Mm-hmm.
and being on the other end as a patient, I'm constantly frustrated by the process of medicine, which
Mm-hmm.
is this box in characterization and
Yeah.
guidelines. And if things don't fit into those boxes, people just don't know what to do,
Mm-hmm.
even though these are extremely clever people. And also, there's a lot of pressure for them to not prescribe antibiotics and to also follow guidelines. And so
Yeah.
it can be difficult now for people to really be thinking outside the box. Of course, you do get champions that are capable of doing this. Yeah, diagnosis of this sort of thing, it's tricky. You know, some people see it as a distinct disease, some people see it as a form of recurrent infection.
Mm-hmm.
I see it as probably, an umbrella term that really probably encompasses a number of different types of diseases. So you could have these chronic or embedded infections that are persistent and they stay within the
Mm-hmm.
urinary bladder. Or you could have these infections that are highly recurrent. And so it's hard to define that. I think we really do need very large, longitudinal,
Mm-hmm.
multinational studies to really sort of identify the patterns of what this looks like and to come up with some hard criteria that could be used medically. It's also tricky because we know that an infection, even if it is resolving, it can leave behind a signature that changes the bladder lining,
Mm-hmm.
changes the neurons or the nervous system within the bladder and how it responds. So even though the infection may be gone, the consequence of the infection can lead to things like chronic pain, chronic inflammation.
Mm-hmm.
And so there's a lot of things there that really need to be teased out from basic discovery research, such as researchers like myself,
Mm-hmm.
as well as doing large clinical studies to try to understand that. But look, I mean, I would think it's going to look something like having frequent episodes within a period of time. You know, like we know recurrent UTI is, two UTIs in 6 months or three in a year. And so, it's probably going to look like increased numbers within that time
Mm-hmm.
frame of symptomology or infections. It might also look like the sort of number of infections with persistent symptoms throughout that time. So there's no sort of relapse or recovery period. But like I said, we really need large studies to convince the field to do that. You know, medicine's not going to move unless we have very large studies to
Yeah.
prove this. And of course, we need the funding and we need the awareness to be able to get these sort of studies done. And we've got to convince our funding agencies and the community that this is
Mm-hmm.
something that's critical to and of a critical need for women's health.
Yeah, I think patients get it. One of the main reasons that people find our website is because they have had a standard culture, gotten a negative result, have clear symptoms of a UTI. For people who do have that experience over and over, do you have any advice for what they could discuss with their doctor to try to find answers?
Yeah, I mean, look, it's tricky. I think, trying to find people that have experience in dealing with these problems. So here in Australia, we have some really great pediatric urologists,
Mm-hmm.
and we work with them, and we've established the first pediatric chronic UTI clinic, but there's nothing that exists for adult women in
Mm-hmm.
Australia. And so, doing your research, finding the doctors that are actually willing to go outside of the typical norms and really work with you to understand this, I think is important.
Mm-hmm.
Uh, Being educated about the diagnosis, so challenging that. So, for example, saying, do we know whether this is reported as contamination, for example? If it is contamination, can we actually get the results
Yeah.
next time to say, well, what is the bacteria anyway, even though there is contamination? Would I then have an infection? Just being aware of these sorts of things can
Mm-hmm.
really help to leverage those discussions. And again, from my personal experience, being educated in that space in relation to your condition can really help you to educate your doctors, but also more importantly, I would say it's critical to work collaboratively. You don't want to be telling them what to do, but you want to be working collaboratively and saying, this is my health and
Yeah.
this is my understanding or my concerns. Could we explore it in this way together? So I think reaching out and finding what's available to you in your area at that point in time by finding specialists that are skilled in this space, for which there are few, unfortunately. And
Yeah.
then also providing, evidence-based information and working collaboratively with your medical team, I think is probably the best way to pursue this at this point in time.
Yeah, and I know Chronic UTI Australia has some information about clinicians for Australian residents, and Live UTI Free can
Mhm.
share information about a lot of countries as well. But you're right, it's difficult to find those types of clinicians, and we're always trying to find the types of clinicians that want to work with patients in that way. And so if you do hear of any, send them in our direction too, because we'd love to be able to share them with other patients. What you
I
mentioned
think what
about,
you find happens, sorry, Melissa,
all
is
right,
that it's sort of a condition where people don't know what to do. Like it's
mm-hmm.
outside of GP's realm. It doesn't fit within
Yeah,
typical infectious disease because they're normally dealing with severe life-threatening infections or
yeah,
chronic infections like HIV in the hospital setting. It's not something that you typically hospitalized for. So those sort of clinical microbiologists, infectious disease physicians aren't seeing it. A
yeah,
lot of urologists tend to be dealing more with sort of bladder cancer and structural problems, and they're not really dealing with this. Urogynecologists are typically dealing with other important women's health issues.
yeah.
And so they kind of fall in
Through,
between again
yeah,
these
they really
baskets that
do.
medicine
Yeah,
have. Sometimes it's nephrology if it's recurrent kidney infection.
yeah,
So it's kind of there's sort of no clear path of where to go, and the
yeah.
primary general practitioners really don't know where to refer people to, and that's part of the problem. And then they're doing their best within the guidelines of what they know,
Hmm.
but it's really tricky because there's a lack of education within
Yeah.
the field, and there's also a lack of where do I go? There's no clear specialty for dealing with this infection.
Yeah, you've kind of described the exact problem that we come up against all the time. There isn't a specialty for recurrent and chronic UTI patients, and it's not taken seriously. It's seen as a benign condition that nobody really wants to deal with, and that there's just patients all over the world trying to find the right type of clinician. And we always
Mhm.
say there isn't a specialty for it. It's whether the clinician takes an interest in the topic, and that could be in
Mhm.
any specialty. And that's what makes them so hard to find.
Exactly. Totally agree.
But you mentioned the contamination thing, which kind of leads to the next question. We know now that the bladder isn't sterile, that there is a urinary microbiome, but do we have enough information to understand what would be considered good versus bad in the bladder in terms of microbes?
It's always a bit of a black box, right? I mean, it's really hard to know. I mean, we're talking about thousands of different microbes that are existing within this community. And unless you sort of systematically test every single one of them in various different systems, it's
Hmm.
very hard to know that. I think what's important is that any pathogen has the potential to be pathogenic, whether it's naturally occurring or whether it's something that's sort of invaded into that space,
Hmm.
depending on what the host is doing, right? So are you immunocompromised like me because you've had a transplant? Are you a postmenopausal woman? Are you somebody with a structural abnormality? Then,
Hmm.
in all of these sort of circumstances, these pathogens could become problematic. But for the most part, it's hard to distinguish. So, if we take something like E. coli, which is the main bacteria that cause these infections, as you know, right?
Hmm.
And we talk about something like chronic UTI, which we've already discussed is this embedding of these pathogens within to the bladder lining, right?
Hmm.
You would assume that only the bad bacteria do that. But the interesting thing is the good bacteria do that too. It's
Hmm.
part of what bacteria do to replicate and survive and just do their bacteria things, right? But how do we then distinguish which is good and which is bad? Again, we can't look at the bug, we've got to look at the host because the
Hmm.
difference in that context, even though the bugs, the good ones, can still get inside and hide inside the bladder lining,
Yeah.
that's not necessarily the bad thing, is having bacteria there. The
Yeah.
trick is, are those bacteria actually causing problems? Are they causing activation of the immune response? Are they causing inflammation? Are they causing death and shedding of that epithelial lining? Are they causing remodeling of the bladder? These are the things that are important, and they're difficult questions to answer that we can't just get from microbiome analysis. We need to do a lot of functional studies to understand that. And of course, the only way to really test that is to test one pathogen at a time. But
Hmm.
in reality, these pathogens exist in very complex
Yeah.
microbial communities. And so I don't think we'll ever really have a distinctive answer other than when we have very clear cases of diagnosed infection in humans where we could say this is the pathogen that we think has caused that. But it's always a bit of we think. Which is also why antibiotics are a bit tricky because
Yeah.
they're often generalized, they're not very specific, they don't really get to the urinary bladder as well as they do to other tissues, and
Yeah.
then they're potentially disrupting the balance of the bacteria or the good bacteria, if there are good bacteria in there, and not just targeting the bad bacteria that are causing the infection. So it's you can see why it's just so complicated, and even for scientists to try to dissect this, it's a bit of a nightmare.
Yeah, it really is. And we also can't look at the bladder in isolation. Can you explain how the microbiomes of the gut, the vagina, and the bladder are all interconnected?
Yeah. So, again, this is another really interesting topic, right? And one of the things that really frustrates me is that people tend to just blame women. So they say
Mm-hmm.
anatomically, you have a shorter urethra.
Yep.
Anatomically, your urethra is closer to your anal opening, and anatomically, you've got the vaginal opening in that
Mm-hmm.
space too. And you guys don't wipe properly and you're unhygienic, so it's all your whole fault, which just
Yeah.
drives me absolutely mad, right?
Mm-hmm.
Because in older men, we see significant increases in infection. And in very young boys, we see very large numbers of infection. So it's
Mm-hmm.
not just urethral length because these things don't really just change as you get older, right? Anatomically, you're the same. What's changing is what you do as a host, your
Mm-hmm.
immune response and the way you deal with these infections. So I think there's a lot of naivety there in terms of these
Yeah.
sorts of things. Having said that, there is important evidence to suggest that bacteria that come from the gastrointestinal tract, so these uropathogenic E. coli can be detected in the gastrointestinal tract, and it's thought that they can bloom and replicate there, and then essentially they can colonize the urethra and they can ascend from there. So
Mm-hmm.
there is thoughts thinking that the gut microbiome, so the bacteria that are in the gut, could be an important source of these uropathogens.
Mm-hmm.
In terms of the vaginal microbiome, we know that particular bacteria, so particular species of lactobacilli, are important for protection. And so I don't think it's just as simple as the bacteria again, like the lactobacilli, but it's sort of what they're doing in the host. I think,
Mm-hmm.
they're probably creating more of a protective environment or a healthier microbiome environment or a healthier lining environment that just is less likely to be infected by these pathogens. Now, of course, it's not just that some women are unfortunate and come across these pathogens. They're
Yeah.
there all the time. Even healthy people can have them in their urine, and even at high levels, that would be diagnostic of an infection, but they have
Mm-hmm.
no symptoms.
Right.
So that's the other problem with these diagnostics is that you can have the level of bacteria in your urine to say you got an infection, but you got no symptoms. So do you really have an infection? So it's complicated. But in terms of how they're connected, I think, yeah, in summary, the gut can be a source of some of these
Mm-hmm.
uropathogens, and the vaginal microbiome, we know from some evidence, has some protective species that can help to reduce the likelihood of having UTI.
You mentioned earlier an infection leaving a signature in the bladder. That could be
Mm.
related to this next question. Could antibiotics disrupt the urinary microbiome and repeated antibiotic use make someone more susceptible to future infection?
Yeah, I mean, I think it's very feasible and plausible, right? I mean, I don't know that there's really good hard evidence to say that that's what's happening, so we have to be
Mm-hmm.
careful how we interpret that. But it makes physiological sense. You have a community of bacteria that exist in harmony under homeostasis or normal conditions. And so if you disrupt that, then you're essentially removing some of your frontline defenses, your
Mm-hmm.
soldiers at the castle being your bladder lining. If you get rid of those guys, you've moved a defense mechanism. It allows the bad guys to come in and sort of attack that castle wall sooner. And so when you think about it like that, it's very plausible. And obviously, if you have ongoing, courses of antibiotics, not only are you going to disrupt the microbiome that's in your urinary bladder, but also in your gastrointestinal tract, and that's going to affect your gastrointestinal health as well as your
Mm-hmm.
vaginal health as well. And we know, for example, having fungal infections such as thrush is really common after antibiotics.
Yeah.
And so that's obviously disrupting the vaginal microbiome and potentially these protective lactobacilli as well. So we use these antibiotics with the intention of getting rid of the pathogen that's causing the infection, but
Mm-hmm.
of course it's a bit like an atomic bomb. We're kind of doing it to all the other
Yeah.
bacteria, good or bad, across the entire body that are responsive to that particular antibiotic. So, of course, that's going to cause disruption. Whenever there's disruption, whether that's anatomical, older age, hormonal changes, transplantation, immunosuppression, whenever there's a disruption, whether it be antibiotics or any of those things I just
Hmm.
mentioned, that's going to make us vulnerable in some way. So, yeah, it's feasible and plausible, but is it proven? No.
Do you think still we might move away from antibiotics as the future of UTI treatment?
I would love that to be the case, yeah. Or at least as a combination therapy.
Hmm.
I think, antibiotics is probably great for the vast majority of uncomplicated infections, occurring for the first time, right? I
Hmm.
think it has a really important place there. We're certainly not going to be moving to really complicated, expensive immunotherapies for everyone. Because, I think of it a bit like a spectrum with COVID, and COVID's a great example because people can understand that it had such an impact in the community.
Hmm.
Some people had the infection, no idea they had it. They're
Yeah.
asymptomatic, right? Some people it's like a mild cold. Some people, sort of got more like flu-like symptoms, right up to being hospitalized,
Yeah.
right up to ventilation, right up to death. And of course, UTI is exactly the same. It
Yeah.
has that whole spectrum. It's not sort of a yes/no infection, right? And so I think that's really important. So on that lower end of the spectrum, or even the high end of the spectrum, where you're in with urosepsis and it's life-threatening, then of course we need antibiotics in that case. And of course we need antibiotics as a first line therapy. But where things like immunotherapy come in, so non-antibiotic therapies that target the host rather than just the bug,
Hmm.
that's going to be important in the sort of conditions we're talking about. So these highly recurrent infections or these chronic embedded infections where antibiotics aren't working, is there
Hmm.
something that we can do to target the host that can rebalance the host immune system or the host just in general? So that we can then clear the infection, or
Hmm.
so that then antibiotics might actually be effective. So I think antibiotics need to always be there,
Hmm.
but I don't think they should be the only weapon we have. I think we need to have additional tools.
There's a lot of patient interest in non-antibiotic approaches. One thing that people often ask us about is fecal microbiota transplant, or FMT. Do you think that could become something that is used for recurrent UTI patients more frequently? I know some patients already seek out this type of treatment, but it's not something that's offered as a standard approach.
Yeah, I mean, look, it could. I mean, it really depends, I guess, for that individual of where the pathogens are coming from. If for them their disease is being caused because it's their gastrointestinal tract is the source of these uropathogenic E.
Hmm.
coli, and for that individual that's happening, then this could well be a great treatment. So I think before that, we probably need ways of trying to distinguish or subset patients as to what's causing it. So is there some kind of abnormality in the bladder or a vaginal disruption
Hmm.
or hormonal disruption or anatomical abnormality, immunosuppression, genetic cause, whatever it might be. But for a subset of patients, sure. I mean, it could be that they just happen to harbor these bacteria and you just constantly getting these blooms and that's happening.
Hmm.
But to assume that would work for everybody, I think would be tricky because I doubt that everybody's going to have that cause of infection, even though it might be a common cause of infection.
Yeah.
So could it work if you have, disrupted microbiome and you have other gastrointestinal diseases and these bacteria are outcompeting other bacteria in your gut, then it could well be a therapy. Does everybody need to be pursuing it? I mean, it's tricky. I don't think that there's the evidence there, right? But it's
Yeah.
always fun to joke about these things. You're going to get poo shakes or poo fusions or even crapsules or whatever you might want to call these things.
Yes.
Like it's an interesting and engaging topic, so you can see why people kind of navigate towards it. But I think
Yeah.
we need to know how to stratify patients to make sure we give them
Hmm.
the best care. So really, we need to move, Melissa, towards personalized medicine. We're identifying,
Agreed.
like we do for other diseases,
Yeah.
what kind of treatment. So if we take respiratory disease like asthma that I used to work in, we know that there's these really great new immunotherapies. If we just give it to all asthmatics, it doesn't work. And the
Hmm.
clinical trials showed that. But when you stratify those patients based on whether they have high levels of
Hmm.
the sort of immune factors that are driving disease, and then you use immunotherapy against that, of course, it works really well in that subset of patients. So that's a great example of it's not just a one size fits all. We really need to understand more about subsets and individual patients
Hmm.
through personalized medicine and then have targeted approaches for those individuals.
Thanks so much for watching. I hope you found this expert video helpful. If you'd like to learn more about this or related topics, be sure to check out our other videos or head over to liveutifree.com for related articles. We'll drop some links in the video description. If you like what we're doing on this channel, you can support our work by hitting subscribe here on YouTube, and don't forget to tick the bell so you'll be notified of our future videos. Thanks again for watching, and until next time, keep asking questions and pushing for better solutions.